The next session is a panel discussion, and it's titled Educating the Caregivers of Tomorrow. And this session will be moderated by Dr. Robert Selepe, Clinical Transformation Officer at Telemedicine Healthcare Group. Dr. Selepe. I'd also like to call on the other panelists, Dr. Rajiv again, Eshwari, Director eHealth, Department of Health, eHealth at the Department of Health in KZN, Professor Maurice Mars, Head of Department, Telehealth at UKZN, and Ronel van der Vaart, Nursing Manager at Netcare. Please give them a round of applause.
Thank you very much. First of all, I'd like to welcome our panelists. We already have heard about Dr. Rajiv here. For those of us who were here yesterday and this morning, he's just presented paper. But I'm going to give a chance to, starting with Ronel, welcome. If you can just introduce yourself and just let us know what you do, and then from there we'll move over to Professor Moss.
I have been involved in this all the time. I served on the National Telemedicine Steering Committee in fact, 1998-99. And we've been trying to implement telemedicine, and I will talk a bit later about some of the barriers that in fact, are faced.
Thank you very much, Professor. Dr. Eshwari, the caregiver. Why the caregiver? What is the role that the caregiver plays? In the past day and today, we've been talking more about technology, the healthcare provider. Who is the caregiver, and what areas does the caregiver play?
Yeah, caregiver is a non-medical person. They are mostly all over standard 8 or standard 10. They are employed by the Department of Health. I'm talking about KZN, but it's the same all over South Africa. In KZN itself, we got about 10,224 caregivers. They go from house to house. On an average, they visit about 50 households per month. 3 to 5 households per day. They are workers, they walk, they don't have transport, they walk from house to house. So that's why they cover about 3 to 5 per day.
And the importance, what is it that as us delivering health, what is it that they are helping us to achieve as they do their work?
See, one of the things they are mandated to do is to collect information from every household. So number of people living in the house, they have a form that they get filled, they fill it up, and they bring it back to the clinic. And without technology, I'm talking about, we have done some initiative, we'll talk about it later, but they collect the information, they bring it to the nearest clinic, and from there it gets sent to a central place where data capturers sit and capture information. And there's a backlog of 6 to 8 months.
Great. And for the past days, like I said, we've been talking more about the doctor in his rooms, and let us get a picture of what's happening in the hospital. We forgot about our hospitals. Ronel, if you can let us know, in the hospital, the role of the caregivers there.
I think in the hospital we see our nursing staff as our caregivers, and we tend to think that they're all on the same level, which they are not. There's 3 distinct categories, which means that they're also on different levels of education, and also then the different generations of nurses. So not everybody buys into the technology in the same way. But as much as we see the challenges of it, we also see it as an opportunity, because nursing has become something that people don't want to do anymore. The younger generation don't want to go and nurse. And we're also hoping and seeing this new introduction of technology as a way to make it more attractive for the younger people again, so that they see that we are embracing all of this new technology. I think just from a practical point of view, the big challenge there is that you have some of the hospitals, I'm not talking private, I think in the public hospitals it's much worse, but we have up to 700 nursing staff working 4 different shifts. So it is quite challenging to get them trained into the new technology. And then it's not only your permanent staff, you also have temporary staff from the nursing agencies that then have to join as well. So it takes a lot of collaboration there. But
You've spoken of new technology.
Yes.
But Professor, there's basic technology that we're using today. What is one of the basic technologies that has achieved so much especially in the research that you've done. There you go. Can you just brief us and let us know how caregivers, have used the technology to advance the delivery of healthcare in South Africa?
Well, I'm going to start by just talking about something else to, in fact, follow up, and then I'll come back to that. I think we all have to understand the state of health within Africa. In South Africa, apparently, we have 77 doctors per 100,000 people. But about half of those are in Australia, Canada, etc. They stay signed up. Okay. In fact, in the state sector, the figure hovers around at about 35 per, in fact, 100,000 people. In the States, it's 270 per 100,000 people. Okay, so there's a big difference. The next problem that we face, because we don't have enough doctors and we don't have enough specialists, even though we don't have enough doctors, the simple thing is to say, bring more into the medical schools, make more medical schools, train them. But who's going to train them? We don't have the specialists anymore in the infant medical school. In Durban, 1/4 of our departments do not have an HOD. Why? Because only the old people are in fact left. That whole middle layer has gone into private practice. So that's actually, in fact, a long way to get back to the point. Task shifting has to be the way to go, right? As was said, people are gathering data. The problem that I've experienced in attempting to implement task shifting is that there are unions, and there is a scope of practice, and there has to be national buy-in to a different idea, right? That we in fact need to shift tasks. We need to allow nurses to do far more than they do now. And I will get back to the point now. I've been involved in telemedicine for probably, for about 20 odd years. And the one thing that we've seen everywhere in the world, that if you consult, be it by video conferencing, over your phone, by email, after you've been given the same answer 5 times, actually something happens. Then in fact, next time you see that case, it's easy. You've in fact learned something. So the practice of medicine, and especially telemedicine, allows people to in fact learn. The whole concept of M-Health, in fact, when people began talking about it in around 2005, 2006, I must say that I was skeptical based on the standard of phones in those days. But these phones are a computer. And after we have enough cheap bandwidth and data, we won't need a, in fact, video conferencing setup anymore, because we'll be doing it on our phones.
That's right.
And bear in mind, doctors have been using the phone since 1879. The first recorded phone consultation. The phone was only invented in fact, 1876. So we've been doing it for over 100 years. Mm-hmm. And we think it's something new. It's not. There is nothing new. We just have to get our minds, in fact, sorted out and certainly focus on task shifting.
I think that's a great point you're making, Professor. Doc, you said that in KwaZulu-Natal you have already caregivers going around. Can you just briefly let us know into how they're collecting the information? What sort of technology? Because every time we talk of technology, we're thinking high-powered stuff. Just brief us on,
Yeah, we have implemented in 2 districts. One has taken off. It's in Amajuba district. We have given them a digital pen and a cell phone. They go from house to house. They collect information using a digital pen on a digitized form. It's called annotate dot matrix format. So they fill it up and take pictures of the people in the household, and then it takes about 10 seconds for the information to. It's a web-based solution. It goes onto the web in 10 seconds time. If by chance there is a person who's a TB contact, for example, it would not be a good example, but if there's a problem in that particular household, the nurse at the clinic gets an SMS to say there is a problem in the particular household with the GIS coordinates. So the nurse can actually react immediately. So that's what we're working on. This came out of what the national minister said. One, they said, anyhow you're going into the community, why don't you do a hemoglobin, a cholesterol, and a blood sugar, so they can pick up early diabetics. We can pick up people who are anemic. So we have actually incorporated, that's what I spoke about in one of the slides, to give them a kit. So the family health teams where there's a nurse practitioners in gets the kit with the point of care devices.
We'll come back to the kit that you spoke about, because the topic for now is educating the healthcare giver of tomorrow. In the hospital, can you just give us a brief sense of how is Netcare, for instance, going by in terms of educating the nurses?
I think we've spoken a lot of
technology.
Yes, a lot of the previous speakers have spoken about the change management that goes along with it, and I think in our experience that is probably the biggest factor there, because people don't learn if they're not interested to learn. And since the time I've had my first lecture on change management, people have said, what's in it for me? And I think inherently nurses want what's best for the patient. So for them, it's about what's in it for the patient. So as soon as we can get that message across of how this is going to make it better for the patient, if we introduce this technology, we get much better buy-in, and then it's better to train them. We've also learned now, and sometimes we learn lessons the hard way, but we've also learned that it's often we change processes at the same time that we implement new technology. And it's better for us to change the process first before we implement the technology. Otherwise, people tend to think that the technology is there to make their lives busier and to create more work for them. So, and also it also includes this task shifting sometimes, because it might be that because we change the process, you're going to do a different task.
That's right.
And then it makes the training easier at the end of the day. So I think, and also I'm not sure, I think most of the audience probably know that the nurses training is going to change. There's a new curriculum, new qualifications that's going to be introduced very soon. And the computer literacy is going to be part and a requirement of this new qualification. So it's going to be introduced to them from the time they start their training.
I've got two questions I want to pose to the professor and doctor here, but just to the members of the audience, I am aware that there are professionals from different spheres. I would like you to participate in this and give us your input. I know the people from telecommunications. If there's projects that you've launched where you've educated caregivers, please, we'll give you a chance later so that you can give us input so that we understand exactly how we can achieve the job of educating our caregivers. Professor, you are involved, and by the way, I must remind you that the University of KwaZulu-Natal is doing a great job in terms of telehealth, and Professor Mas has been at the cold face of training and educating. Every conference you go to, you learn something new from him. You are at the forefront of training and educate. Where do you see, or how do you see us being able to educate the caregiver, the non-medical person, the person who's in the community? How can we help them to learn or to understand the new technology that we're using to deliver health?
Okay, I'm going to again start by answering this in an oblique way. I think it's important that we understand the meaning of words. Are we talking about educating, which leads to a formal qualification? Mm-hmm. Are we talking about training, which is the acquisition of a skill? Or are we talking about raising the awareness of people?
I think I would like us, and I'm happy that you came there, Professor, let us look at acquisition of skills, and also let's talk about the qualification side.
Okay. Right. Skills acquisition. The, in fact, reason that we haven't pushed very hard among our in fact, undergraduates at our medical school, pushing them to practice telemedicine, we've given them cameras and sent them out and asked them to take photos and send back emails, etc. There is no point in training somebody to go into an environment in which the infrastructure isn't there. So that's the first concern that, in fact, I always have. Make certain that people need those skills, and they will learn on the job. I'll just ask the audience, how many of you had to be trained to, in fact, use your phone? Huh? One.
Two.
No, but the in fact point is that there is a tremendous amount of IT learning and skill acquisition that occurs by, in fact, osmosis. We get stuck. Somebody shows us. There's a specific need that we have. We go and find out the, in fact, answer. Right? And that is informal. But certainly skills training, you must only train people in skills that they're going to have to use in the field. Otherwise, you're wasting your time, their time, etc. Right? So that's formal qualifications. Okay, so if in fact we broaden that and take it out of the e-health sphere. So, okay, I can in fact share with you an experience from the upper end. I've got 11 PhD students scattered over Africa. I occasionally see them at a meeting somewhere in the world. They don't ever come to Durban. Right? The in fact reason they're doing PhDs is that they're going to be in senior management in their departments of health. So at that level, one needs to actually understand the in fact levels. But let's take doctors first, nurses second, and the in fact healthcare workers. Doctors, in South Africa, we're in dire straits. We're going to have to, and I think you will start to see this within the next year or two. The medical schools are going to have to share teaching. So, for example, in Durban, we taught pediatric surgery from Durban to Mthatha as far back as 1980, as in fact 2004. Right? So there has been sharing, but we need the deans of the medical schools to sit down together and say, hey guys, we can't manage it on our own anymore. Let's share the workload. So you'll have to do a seventh less work. Okay? That is an approach there. In fact, nursing, I'm still confused as to what the new curriculum is actually going to be. And because I work in a health science college, we've got all the nurses doing a in fact degree, and I'm too far away from the cold face of the hands-on nurses being trained in the in fact state sector. But again, the people have to want to learn, and that is a problem. It isn't a matter of just getting a piece of paper that earns you in fact money. And I think the phone will be an easy way of getting nursing students to in fact interact. There have been some studies from Jennifer Chips down in the Western Cape where she's set up Facebook groups, set up groups on Viber, for example, and then the in fact students are actually talking to each other, and if they have a problem they're actually learning from each other, and I think we're going to see far more of that. But certainly I've been teaching by video conferencing and Skype into South Africa and Africa since in fact 2001, and it's not difficult. But again, you've got to learn different techniques. It isn't as if you're standing up at the blackboard. You've got to interact. You've got to stop. You've got to ask people to make certain that the people in the different areas all in fact join in. But I'm not going to talk further about nursing because my dean is a nurse, and in fact she will stamp on me if I say anything about nursing.
Thank you very much, Professor. Doc, the health kit. Now, when I first received a telehealth glucometer, reading through the manual on how to use it, how to set it up, how to download an app, I felt like I'm writing an exam the next day. It was such an anxiety-generating situation. You give somebody a health kit like that. How are you guys educating your caregivers, especially those having a health kit there? I saw it's got a glucometer, it's got a number of other gadgets. How are you educating them? Are you taking them together into a formal setting, or what happens?
When we hand over the kit, we don't give it to any caregiver. It's going to be a nurse in the family health team.
Right.
So somebody with a clinical background. And it's easier for us to explain it to them how to use it, because it doesn't take more than a few minutes to do a blood glucose. And then they don't have to, it's the way we have configured it with the software is that it uses Bluetooth to put it onto the system. So they don't have to enter information anyway. Right. So there is we prevent the manual error that can happen, human error that can happen. So that's the Bluetooth that happens. But before that, I'd like to emphasize on the caregiver training. For caregivers, the next progression in career progression is to become a health promoter. So we actually identified a few of the enterprising ones out of the 10,000. About 115 of them have been sent for training for the last 2 years. They have been trained. They're going to join us now as health promoters. So what we're trying to do now is to the community caregivers in the district where we have implemented the ward-based outreach program is that we give them a smartphone as well. So what we are looking forward to is help from the industry that has already developed an app. We give them an app to say, okay, this is it, and then they can actually show it to the community members if they require, if they have to talk more about what they can, I mean, for health promotion purposes.
Right.
Yeah.
And I think the other thing, sorry, Professor, you wanted to say something. One of the things that health, caregivers do out when they're out in the community, particularly in a setting that the doctor has spoken about here, is monitoring adherence of patients. Sometimes patients struggle a lot with taking medication, especially those that are taking highly active medication, like your HIV drugs and anti-cancer drugs and things like. What is the experience and the benefit in particular? Because I know KwaZulu-Natal and the Western Cape have achieved quite a lot. Those are two provinces that we're hearing a lot about, their achievements in terms of adherence.
The very fact that the community caregivers have been given an area, about 50 households to visit, and they periodically go and visit them regularly. And then once they pick up issues like they've not collected the medication, then they actually make sure that they are brought back to the clinic so that they can. So adherence part of it, we still have a lot of work to do on if they're taking it regularly or not. But they train in the community, they talk to people in the community to say, so-and-so person does require medication regularly, please keep on checking them. But that's what I believe is happening on the ground.
Right. I think in the audience, I would like to get some input while we're still on the subject of educating. If we can get some input on the audience, there's a gentleman over there and then there's somebody here.
This is to the professor. The response to an earthquake is different to a response to erosion, even though the result may be the same. Yeah. With erosion, people ask you, I'll speak to insurance to fix whatever's broken. But when there's an earthquake, everybody jumps in, people take their resources, they take their time to go and help and make sure that everybody's sorted out. I hear you speaking about, you don't want to even train people about telemedicine anymore because they're not going to use it. But if you've got a shock effect where you're training them about something that needs to be done, but there's apathy, either in industry or government, and people are starting to demand this thing, don't you think it'll then trigger a response that'll say, let us do something about this thing that these people are trained on how to do it so that we can put resources together for it? Because disaster recoveries, disaster situations, they trigger those funds that are immediately available. We get it from somewhere, we take from Paul, we give to Peter, at least we know we're addressing an issue.
Yeah, thank you. It seems though I may have not stated my case adequately. I'm in fact not saying that we're not training people in telemedicine, we're not training medical students in effect telemedicine. The most exciting thing to me within the field of telemedicine is something that has just happened spontaneously in fact Durban. Doctors, it began with the junior doctors. Let's just give you the example of in fact the burn service. The most important time in the assessment of the burned patient is when the in fact dressings are changed. And then there was a shortage of burns specialists at that time. Somebody had gone on leave, and there was a junior doctor left on his own, having to make the assessment. So he says, I have a camera. So he takes some photos of it, and he in fact doesn't send them. He chases up to theatre and he shows the burn surgeon, and they reach a plan of in fact management. In fact, that then evolved into sending messages in text, and the same's happened in fact dermatology, and we've got widespread dermatology going on with no planning at all, No training. In fact, doctors have found the solution for themselves, and we have some people working on it now. We are hoping to scale that project up for the whole of in fact, KZN. And if we can scale it in KZN, we can in fact scale it into South Africa. So, WhatsApp, simple. People are using it every day. They don't have to be trained. They're taking photos. They don't have to be trained. They're sending text messages. We just have to organize that the information goes back and forth, that there's security, confidentiality, etc., etc., etc.
Thank you. You know, I feel disheartening. Listening to this conversation. I started my research in South Africa. 4 years, almost 4 years now. And at a point I discovered South Africa Department of Health is struggling with e-health strategy. And here we sit 4 years down the line. But I appreciate the effort from KwaZulu-Natal, but really we need to understand the strategy to really achieve IT for healthcare delivery. And looking at the strategy, I think there has been, the gap between academics and the industry. There is no way we have to get healthcare practitioners use technology without taking it to them at the university level. How does this initiative get into academic curriculum? That is the first thing we need to think about. And that reminds me of my experience with UNISA. The UNISA Health Sciences Department, they try to collaborate with the School of Computing to see how they can start educating students, the medical students, about technology before getting out. But the reality is, we don't really understand what is going on in the industry. My research made me to know that there are IT companies out there that have a lot of software that can really assist us in achieving this. And how much are we getting to talk to these people? I know about Oracle. Oracle has got Oracle Healthcare. Oracle is ready to give academic support.
Thank you very much. I think we've gotten your point. There's just another hand at the back. I'd like us to squeeze as many comments as possible, and then we'll respond after that, because time is against us. I think there was somebody at the back. I thought I saw a hand there. Oh, this side, sorry.
I have two questions. One for Dr. Rajiv, if I can. Just around the caregivers who are going out into the homes in the KZN district. Is there any patient engagement in that? And basically, how is the scheduling managed? So how are the caregivers notified of where they need to go, how they need to see patients? And do the patients have any engagement in that process? And then the second question is for Ronel, just around, we know that readmission rates are extremely high, particularly in private sector. In fact, there's quite a lot of buzz around this week with one of the medical schemes who solvency ratio is hits quite a low amount. What is Netcare's view on providing the discharge or managing the discharge process and trying to help patients who have left hospital and trying to stop them coming back in?
Thank you. Prof, can I give you first, shortly, if you can just answer the question of how academics, are not partnering with private IT companies in terms of, developing a strategy. But I know there's a document that's out on that from the Department of Health, our e-health strategy document. But maybe you can comment just
okay,
about the gentleman.
I can just comment about what's gone on at the, in fact, medical school in Durban. First years had to do a computing course since 1992. Simple as that. They can't access their in fact, notes, handouts, etc., unless they can work a in fact, computer. They can't submit their assignments unless they can use a in fact, computer. So that's in fact, taking care of that. I think they've done a similar thing within, in fact, nursing, or in fact, Durban. So that's the in fact, interaction with that industry. Yes, in the early days, we got a fair amount of basic training material from the in fact, large IT houses, and we in fact use them. There in fact isn't any need for us at that level anymore. That may well be appropriate for the community health workers.
Thank you very much, Prof. There's a question from the gentleman.
Yeah, what we have done is the community caregivers, when they go from house to house, they're given two forms. One is a form for collecting information, other one is a referral form that they fill it up and give it to the patient. But at the same time, if they find a problem in a particular household, an SMS gets sent to the nurse practitioner at the clinic, so the nurse can follow up as well. So it's a two-way approach, because giving them a referral letter doesn't mean that they'll land up at the clinic. If they don't come, then the nurse reacts. That is what we expect them to do. It's still work in progress.
Great.
In fact, can I just...
okay.
Just in fact, things aren't always as nice and hunky-dory as they sound. There's been a study out of in fact, Schlabisa, which showed that when they gave community health workers a phone to go and check that people were taking their TB meds, the amount of bad data they got was exactly the same as when the people were filling in forms. The community healthcare workers found it an extra burden to in fact use the phone. And so we have to also think about different forms of incentivizing the in fact use of these forms, because in fact in many parts of Africa and in South Africa there are community health workers who are not paid. They are just doing it out of their service, etc.
They get a stipend, they don't get a salary. They get a stipend, so it's not much. But the phone, what we want to do is, what we are using right now is for connectivity purposes. When they go to the house, they fill in the form. The phone is the one that picks up the GIS code, not the pen.
Okay.
So what we want to do going forward is to give them an app or material that can be stored on a smartphone that they can show it to. In case, just an example is how to use a condom. Not a right example, but they can show it as an audio visual on the phone, and doesn't have to have connectivity for that. So that is what we are planning.
Right. So Ronelle, finally, yes.
I think from a readmission point of view and discharge information, what we're doing currently is on a hospital level, we would monitor all readmissions, and that's where the data that we spoke about a lot yesterday comes in. We need to gather the data to see if there's any trends, and very often we cannot find those trends in our readmissions because we look at the reasons and how long afterwards and all of that. But I think, and then of course we do give the discharge information, and we try to give written discharge information to all patients. But because there is a different role between the physician and the hospital, and the physician is a private practitioner, it's usually more the physician that would follow up with the patient afterwards, and it's not really something that the hospital or Netcare group has ventured into at this stage.
Great. There was a comment to the back, Alison.
Thanks. Just to Prof's point around the use of mobile devices, I'm from Vodacom Business's mHealth unit, and we're quite actively involved in using mobile to extend the reach of services and access to healthcare through the mobile device. And to the gentleman in the front, ironically, to your point, we are working quite closely with academics because they are the ones that actually realize that in order to reduce the cost of healthcare, we need to actually do things quicker, faster, and use the technology that's out there. So to give you sort of an indication, we work with the Department of Family Medicine at University of Victoria around community health workers and how they can digitally capture information. We've run a pilot of around 1,200 community health workers, and one of the outcomes of that was that the technology takes up 20%. It speaks directly back to what Dr. Ishwari was saying in terms of it's about the training. They need to first understand what it is that they are doing, what is their job, and why they're doing it and how do they engage, the tool is the 20%. So we couple quite an extensive amount of training that comes from the universities, and all the university departments are going to be involved with this program. But it speaks to both. It is coming, but we shouldn't get hung up on the technology. The technology is the 20%. The change management and the operating procedures around it are the most important parts about it. Secondly, the Department of Audiology, just to do in terms of reducing the cost of healthcare, they've developed a mobile screening and testing, diagnostic testing solution that runs on a mobile app, which will be launched. It's launched publicly already commercially, but we are taking it into the PHC setting for the community health workers, and that is continuing. It spreads to school health for the 1 million kids that they've got to screen every year, and it also speaks to all the toxicity indicators that we have to start tracking and to start helping address the reduction in the cost of healthcare. So I think it's happening. It's not happening fast enough. But between the use of mobile and academics, we are coming together. The meeting of the minds are coming there. It's just a matter of how we actually extend it out into the populace and into the healthcare sector.
Great.
Thanks for that. Just to answer my colleague here, all the initiatives, what I've spoken in my presentation, what I showed in my slides there, as part of the collaboration, what we do is we talk to the industry and then come up with a pilot, and then we use the academics, the UKZN, the MRC, the CSIR and the HSRC to endorse and say that what you're doing, is it in line with what we're trying to achieve or not. So it's important that we collaborate. That's why I keep emphasizing that we have to work together as the department, the government, academia and the industry.
Thank you.
Finish off with
Professor
just a
Moss,
point.
last comment.
There is a whole new sector of health workers that we haven't even mentioned. In the developed world, home monitoring is growing, and it's keeping people out of hospitals, right? And that gets back to the point that was made. In some countries, you can't see a GP unless you phone the insurer, and the insurer has experts. Now, it's this next level of people who will perform the sorting of all the data that in fact is gathered. And we will probably end up with having more home care nurses than we had before. The one point that I meant to ask earlier on, in fact, nobody can tell me how IT is going to work in the National Health Insurance. How are the data going to be moved? Is it going to be telemedicine? And so up until we understand that, we can't train people either. We need that basic data, at least that basic info.
Thank you very much, Professor. I think, what can we take out of this session? I hope that particularly for the technology companies, you have understood the other side of healthcare delivery, the people who are at the coalface, our caregivers. And I'd like to take this opportunity to thank Ms. Verdevalt, Professor Moss, and you, Doc. I think we've been here for a long time.
Yes.
But I really want to say that we appreciate your input, and I hope we'll leave here and go and think about solutions. If we can just remember one thing, it's all about the patient. It's all about the patient deriving a benefit from what we'll be able to deliver. And also to the audience, thank you so much for your participation. Thank you very much. Thank you, Professor.